بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كيف حالكم؟ إن شاء الله المحاضرة الأولى كانت سهلة. راح نكمل اللي بدأنا نتكلم عليه المحاضرة اللي فاتت. This is the second lecture of the salivary gland. Before we continue in the salivary gland disorders, let's review some of the terminology. So what does sialoductomy mean? It's a surgical opening of the salivary gland duct. Sialo is the salivary, ducto is the duct, otomy is the opening. Then we have also sialolithectomy, is the removal of the stone. You can see in the picture the procedure to remove the stone. You put the lacrimal probe in the orifice of the Wharton duct. Then you make an incision and suture in the proximal part to the stone. Why you put the suture? To prevent displacement of the stone away from your incision. Then you can take the stone out. Sialoadenectomy is the salivary gland removal. Sialoductoplasty is like doing an plastic surgery to the salivary gland duct. During this procedure, first you have to identify the lingual nerve and the Wharton duct to preserve them. Then, as you can see in the picture, a ductal incision is made over the stone, distal to it, and you can extend slightly toward the proximal portion of the duct. Then the ductal margin is sutured with the oral mucosa. Okay, so by doing this way, you remove the stone and you suture the duct with the oral mucosa to be like apart from the oral mucosa. We'll start talking about the first disorder for today, is the mucocele. The mucocele is the salivary gland cyst which contain mucus content. It's caused by a trauma like a lip biting or laceration. As you can see in the picture, it can appear in the lower lip or buccal mucosa. The clinical appearance, it has an elevated, thin, stretch overlying mucosa, can appear as a vesicle filled with a clear or blue-gray mucus or fluid. It also could rupture and refill again. The swelling has a tendency to evacuate by itself. Then it also has a tendency to reaccumulate again. The management of the mucocele, as I said before, sometimes it regresses spontaneously without surgery. And for the persistent lesion, or sometimes when you remove it surgically and it happens again, so for the recurrence, you do the excision of the mucocele. You don't just remove the mucocele, but you also remove the associated minor salivary gland that contribute to its formation. You do this to prevent the reoccurrence. The recurrence rate is from 15 to 30% after the surgical removal. What caused this high recurrence? It caused when you do incomplete removal of the mucocele or the associated minor salivary gland. And it also can be caused by repeated trauma to the minor salivary gland. Ranula is considered the mucocele of the sublingual salivary gland, but it's larger in size than the regular mucocele. It has a thick overlying mucosa. The ranula result from it could be mucus retention or mucus extravasation phenomenon. When it's in extravasation, it results from the ductal disruption caused by the inflammation or the trauma. So that means the duct will be ruptured because either inflammation or trauma. The type could be simple ranula when it's confined and occupied by the sublingual gland only in the sublingual space, superior to the mylohyoid muscle. When it extends through or below the level of the mylohyoid muscle and it goes to the submandibular space and the neck and it could compromise the airway, it's called plunging ranula. The problem of the bulging ranula, as I said, when it goes beyond the mylohyoid muscle into the neck, it compromises the airway. رانيولا باللاتيني معناتها ضفدع صغير، فهي شكلها زي الضفدع. طيب نفتكرها دائما. Here you can see the differential diagnosis of the floor of the mouth swelling that include يعني زي حد شاف floor of the mouth فيه swelling, you can put this in the differential diagnosis. Ranula, lymphopithelial cyst, epidermoid or dermoid cyst, salivary gland tumors or mucoepidermoid carcinoma, lipoma, neurofibroma, hemangioma. The other list is for the differential diagnosis of the midline neck swelling. فاللي قبل كانت floor of the mouth. طيب يعني تحت اللسان. الليستة الثانية عبارة عن الميدلاين في neck in the neck يعني swelling في midline of the neck. في midline إيش عندنا structure؟ عندنا thyroid فيو can consider thyroid enlargement ولا goiter ولا tumor في thyroid or thyroglossal cyst, dermoid cyst and plunging granula. The last list of the differential diagnosis in the lateral neck swelling. You can consider lymphadenopathy, epidermoid cyst, lipoma, infectious mononucleosis, metastatic carcinoma, or lymphoma. The treatment, as we said before, that the ranula is different from the mucocele because it's large. So because it's large, you don't want to go and do the excision immediately. You do something called marsupialization. إيش يعني marsupialization؟ يعني you make a small opening في swelling اللي هو الرانيولا, بعدين you suture الرانيولا في الفلور أو في الوول حق الأورال ميوكوزا. ليش نعمل هذه الطريقة؟ عشان to make it smaller in size. بعدين when you make it smaller in size you can remove it, the lesion easier يعني. Why you do the suture like this? Because you want to decrease the recurrence. The treatment for the recurrent or persistent ranula is to do excision with the sublingual gland. عشان نقول هي ranula تطلع في sublingual gland. Okay? We'll talk a little bit about the salivary gland infection. As we all know, the infection can be caused by bacteria, fungi, or viruses. Acute sialodenitis of the parotid gland, or you can call it acute bacterial parotitis. إيش سببها؟ Changing in the fluid balance in older patients who are debilitated, malnourished, dehydrated, those with a chronic illness اللي عندهم diabetes ولا hypertension ياخدوا medications ولا uncontrolled, compromised disease. All of the above cases, most of those cases will be bilateral. The clinical characteristics of this acute bacterial salivary gland infection, because it's acute, it should be has a rapid onset in each of the salivary gland. It also has to have an erythema, pain, and when you apply gentle massage or little pressure, you will have no salivary flow, or you have a thick purulent discharge of the orifice, as you can see in the picture. The most common organism which cause the bacterial parotitis is the Staphylococcus aureus, because this organism is present as a normal flora and colonizes around the ductal orifice. And during decrease or slow salivary flow, because of either obstruction or dehydration, retrograde influx of the Staphylococcus aureus could happen. يعني تدخل البكتيريا بالعكس بدل ما هي موجودة في النورمال فلورا تدخل من الأورفيس على الدكت. Untreated cases of the acute bacterial parotitis can lead to respiratory obstruction, septicemia, and death. So it needs to be treated as an urgent. The treatment, you can give intravenous fluid عشان قلنا هدول المرضى عندهم dehydration. Then you can give analgesic for pain, antibiotic, but you need to do culture and sensitivity to see what type of antibiotic you should give. Then you can do incision and drainage. Viral parotitis or mump. It's an acute, non-suppurative, infectious disease. It was common before the routine vaccination of the MMR. The viral infections are not the result of an obstructive disease. Because it's a viral infection, no need to give an antibiotic. The sign and symptom could be painful, non-erythematous swelling, as you can see in the picture, of one or both parotid gland. It begins 2 to 3 weeks after the exposure, so the incubation period is from 2 to 3 weeks. Mostly it happens in children from 6 to 8 years, and it resolves in 5 to 12 days after its onset. The signs and symptoms, it has pain, swelling, fever, headache. You need to know the complication of the viral parotitis. It can cause meningitis, pancreatitis, nephritis, orchitis, and testicular atrophy. So the treatment is supportive care for fever, headache, and malaise by giving an antipyretics for fever, analgesic for pain, adequate hydration. Necrotizing cyalometaplagia is a reactive and non-neoplastic inflammatory process, usually affects the minor salivary glands of the palate. It results from a vascular infarction of the salivary gland, of the minor salivary gland. So the causes is a vascular infarction which caused by diminished blood that affect the area. How does this caused? By a trauma or local anesthetic injection for extraction. مش كده لما نعطي palate anesthesia نقول you just give a few drops، ما نعطي drops أو anesthesia كتير عشان حتقلل ال blood supply ويجيني necrotizing cyalometaplagia. Smoking, diabetes, vascular disease, pressure of the denture or the prosthesis. Usually occur from 23 to 66 years old. It could be large from 1 to 4 centimeters, could be painless or painful, and it's a deeply ulcerated area lateral to the medial palatine raphe or near the junction of the hard and soft palate. You can see it in the picture. Could be unilateral or bilateral. This condition needs considerable concern. Why? Because clinically and histologically it resembles malignant carcinoma, the squamous cell carcinoma or mucoepidermoid carcinoma. It heals by itself in 6 to 10 weeks. ننتبه إنه the development of the ulcerated area lateral to the midline of the palatal raphe within 1 week following the extraction. إيش هتكون؟ is a necrotizing cyalometaplagia. فإيش قصدهم لو أجاني المريض وعطيته قبل ما أخلع أنستيجيا وعطيته more than few drops في البالت، ممكن بعد أسبوع يجيني المريض يشتكي من necrotizing cyalometaplagia. Sjogren syndrome. It's a multi-system disease process with a variable presentation. It has 2 types. The first one is the primary Sjogren syndrome or Zika syndrome. It is characterized by a xerostomia, which is a dry mouth, and keratoconjunctivitis sicca, which is a dry eyes. Then we have a secondary Sjogren syndrome. يتكون من البرايمري Sjogren يعني يكون عنده Sjogren ويكون عنده other disease. Usually يكون connective tissue disorders زي rheumatoid arthritis, could be systemic lupus. And causes, it's an autoimmune influence. Symptoms could have an arthritic symptoms, ocular symptoms, salivary gland symptoms. المشكلة اللي تصير عند الجوجرن syndrome which caused the xerostomia is that there will be a lymphocytic replacement of the normal glandular elements. This xerostomia results from a decreased function of the major and minor salivary gland, so it affects both the major and minor salivary gland, and the parotid gland being the most sensitive to the Sjogren syndrome. The diagnosis is suggested by Patient complain about the keratoconjunctivitis sicca, and when you do immunological test, you have an abnormal result. The oral component of Sjogren's syndrome may be diagnosed by the salivary flow rate studies to see the stimulated and unstimulated. You can do a cyanogram that can show a typical acinar destruction. Then you can do the labial minor salivary gland biopsy, which is very accurate for establishing the Sjogren's syndrome diagnosis. How to diagnose the dry eyes or keratoconjunctivitis sicca by the patient complaint. And there is a Schirmer test for the lacrimal flow to see the degree of the lacrimal flow reduction. The result of the Schirmer test are as follows. So if it's normal, you have 15 millimeter or greater wetting on the paper after 5 minutes. Mild when you have 14 to 9 millimeter on the paper after 5 minutes. Moderate when you have 8 to 4. Severe when you have 4 wetting on the paper after 5 minutes. You can see the paper inserted in the eye in the picture. The patients who have a keratoconjunctivitis sicca are in the severe category with less than 4 millimeter of wetting of the paper strip after 5 minutes. The treatment, what do you give for them? You give an artificial tears, salivary substitutes. You can give cholinergic medication like pilocarpine or biotin. Products may be also useful to stimulate salivary flow. You can have a trauma that involves major salivary glands. What a potential sequelae of the trauma involving the major glands? Infection, facial nerve lacerations, because as we said before that the facial nerve runs through the parotid gland. So if this is happened, your patient can have facial paralysis, cutaneous salivary fistula, يعني it will open on outside or extraorally على السكن outside. Sialocele, scar, duct obstructions. This all can be caused by a trauma that involving the major salivary gland. salivary gland tumors في قاعدة اسمها قاعدة 80-20. إيش يعني؟ يعني the major glands include 80% of the salivary gland tumor. The minor gland include 20%. From the 80% of the major glands, 80% happens in the parotid gland. Then the submandibular has 5 to 10%. In the sublingual gland, it's very rare. The minor salivary gland, the palate, consists 55%. Then lips, then the other area, it's rare. We'll talk about the benign salivary gland tumors first. The most common one is the polymorphic adenoma. You also can call it benign mixed tumor. The parotid gland involved in more than 80% of the cases. The minor salivary gland, the most common area is in the palate. The polymorphic adenoma are usually slow growing painless masses. عشان كده هي benign فتتصرف تصرف benign. The treatment, you have to do a surgical excision with the margin of the normal involved tissue to account for a possible irregular projection of the lesion. Parotid lesions are treated with the removal of involved loop along with the tumor. يعني هشيل التيومر وهشيل اللوب اللي هو جزء من الباروتيد جلاند اللي involved مع التيومر. ليش نهتم فيها ونسوي لها أحيانا safety margin؟ عشان small risk 5% it can go to malignant transformation with the long-standing legions of carcinomas. In these pictures, you can see a polymorphic adenoma in different places. You can see how it starts as a small swelling, then it can go very big. Wharton tumor, the only thing I want you to know about it, it affects the parotid gland, especially the tail of the parotid gland, associated with the smoking. It's a slow growing and soft, painless. It's a free movable mass. It's caused by entrapment of the salivary epithelial rests within the developing lymph nodes. The treatment is a simple surgical excision. The malignant salivary gland tumors include the mucoepidermoid carcinoma. It's a submucosal mass that may be painful or ulcerated. We are talking about the malignant. So the malignant usually painful, ulcerated, has a bluish color, sometimes red, and has mucus content. It can go intraosseous from the mucoepidermoid carcinoma. It has an aggressive behavior. It has two types. Low-grade lesions. You had to do wide surgical excision with the margin of the normal tissue. Then you have the high-grade lesion. It requires more aggressive surgical removal. In addition to the safety margin, then you have to do a local radiation. The survival rate for the low-grade lesion is 95% for 5 years. The high-grade lesion have less than 40% for a 5-year survival rate. الصورة اللي تحت تبين lesion بعدين تبينه كيف في الإكس-راي. The second type of the malignant tumor of the salivary gland is the adenocarcinoma. It occurs at the junction of the hard and soft palate. It's a slow-growing asymptomatic masses, usually ulcerated. It has a neurotropic effect, which caused by the preneural invasion. راح تجي حوالين النيرفز وتسوي invasion and propagation along the surrounding nerves. The treatment, wide surgical excision, because it has a high recurrence rate of 14%. Adenoid cystic carcinoma or cylindroma. It is the third most common intraoral salivary malignant tumor. It's a slow-growing, non-ulcerated mass with an associated chronic dull pain. It causes facial paralysis because it has a neurotropism. As we said before, it caused perineural invasion, similar to adenocarcinoma, with the facial nerve involvement. The treatment, you do a wide surgical excision, radiation therapy. It has a very poor prognosis. This is the end of the salivary gland lecture number 2. Please, if you have any question for the first or the second lecture, feel free to send an email. Okay? وفي الأخير اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. بالتوفيق للجميع وفي أمان الله.